You know, usually when we think about treating a medical condition, the solutions make intuitive sense. Like they're highly linear. You
Right.
get a headache, you take a pill that dampens the pain receptors. Or you break a bone, the x-ray shows the crack, the doctor sets it in a cast, and you just wait for the calcium to knit back together.
Exactly. It's problem, physical intervention, solution.
Yeah.
That's the classic model of modern medicine, really.
Yeah.
When we can see the mechanism of injury, we generally know exactly how to fix it. Or, well, at least how to manage the symptoms.
Right, the logic is comforting. But what if the cutting-edge solution to a silent, just agonizingly painful condition that affects up to like 80% of menopausal women involves, and brace yourself here, extracting DNA from trout,
Oh, yeah.
purifying it in a lab, and then delivering it into the most sensitive mucosal tissues of the human body, using either a high-tech automated multi-injection machine or the meticulous precision of a doctor's hand.
I mean, it sounds like pure science fiction. Right?
Yeah.
Or perhaps a very strange cosmetic trend.
So,
But in the realm of regenerative medicine, specifically when dealing with refractory vulvovaginal dryness that just completely refuses to respond to standard treatments, this is rapidly becoming clinical reality.
it really is. So, welcome to the deep dive. Today, we are unpacking genitourinary syndrome of menopause, or GSM for short.
Yes.
And we are focusing heavily on this fascinating regenerative treatment using something called polynucleotides.
Which is such an interesting area of study right now.
It really is. And we're diving deep into a major clinical debate playing out in the medical literature right now, which is how to actually deliver these biostimulators into the body.
The delivery mechanism is everything here.
Right. So we're looking at a great stack of sources today for you. We're weaving together recent randomized controlled trials from journals like Matritis, some real-world case series, and the actual clinical protocols from specialist women's health clinics.
Some really robust data.
Yeah, so, okay, let's unpack this. Because before we can understand why anyone would subject themselves to, a high-speed, multi-injector firing fish DNA into their intimate anatomy, we have to look at the reality of the problem this is actually trying to solve.
We do. And we have to start with genitourinary syndrome of menopause, which is a sweeping term that recently replaced older, honestly more stigmatizing labels like vulvovaginal atrophy.
Right, the language shift is important.
It is. And it affects 50 to 70% of postmenopausal women, with some epidemiological studies showing prevalence as high as 80%.
That is a staggering number.
It's huge.
Yeah.
And these are not minor inconveniences we're talking about here. We were talking about profound vaginal dryness, burning, itching, and dyspareunia.
And dyspareunia is the clinical term for severely painful sexual intercourse, right?
Exactly.
Yeah, I was reading through the surveys you shared in our research stack, like the VVAS study. Something like 80% of symptomatic women reported a fundamentally negative effect on their lives.
It's devastating for a lot of them.
It is. It's severe interference with sexual intimacy, sleep disruption from the constant itching, and just a massive quiet hit to their psychological well-being.
Because nobody talks about it. And the underlying cause of all this suffering is basically a total structural collapse of the tissue.
Right.
When estrogen levels plummet during menopause, the tissues in the vulvovaginal and urinary areas, they fundamentally change. They lose their blood supply. They lose their elasticity.
And the collagen. Right.
Yes. Crucially, they can lose up to 75% of their type I collagen.
Wow.
Yeah.
Which is the primary structural scaffolding of the tissue. I mean, if you lose 75% of the physical support holding a building together, the walls are going to crumble.
That's exactly what happens biologically.
Some of the clinical descriptions in our sources describe the tissue visually transforming, like becoming incredibly fragile, pale, and covered in petechia.
Yeah, petechia are essentially tiny pinpoint red dots. They appear because the capillaries, the tiny blood vessels just under the surface, they've become so incredibly fragile without that collagen support that they simply break and bleed under the slightest friction.
Oh, wow. So you can imagine why any kind of physical contact, let alone intimacy, becomes just agonizing.
Absolutely agonizing.
And the really cruel part about GSM is that, unlike hot flashes, which can, eventually fade away as the central nervous system adjusts to the new hormonal baseline of menopause, GSM usually just gets progressively worse over time without intervention.
It doesn't just go away.
Right. Which naturally brings us to why the current first-line treatments are failing so many women. If you go to a standard general practitioner right now complaining of these symptoms, the first thing they usually tell you to do is go to the pharmacy and buy some over-the-counter lubricants or hyaluronic acid moisturizer.
Right, those are the standard conservative protocols. And they provide temporary hydration to the very top layer of the mucosa.
But just the top layer.
Right, they don't penetrate deeply enough to reach or stimulate the fibroblasts.
And the fibroblasts are the cellular factories that actually build the collagen.
Exactly. Because these creams aren't reaching the factories, they have absolutely zero regenerative potential.
It's like spraying water on the dry leaves of a dying plant instead of fixing the depleted, nutrient-starved soil at its roots.
That's a perfect way to put it.
The leaves might look wet and shiny for an hour, but the plant itself is still dying from the ground up.
The soil remains completely depleted. And because the relief is so fleeting, the dropout rate for these superficial treatments is incredibly high.
I imagine they just get tired of it.
Yeah, women simply get frustrated with the mussy, ineffective daily application. So doctors will often pivot to prescribing topical estrogen creams.
Right, which makes sense hormonally.
It does, but a significant portion of women drop out of that therapy too. They harbor deep fears of systemic side effects, like breast cancer risks.
Even though localized topical estrogen has a vastly different, much safer profile than systemic hormone pills, right?
Right, but the fear is still there.
So if the creams just wash away, what about the high-tech energy devices? I feel like over the last few years, every medical spa and boutique gynecology clinic seems to be heavily advertising vaginal lasers to fix this exact issue.
They are everywhere. Energy-based devices like fractional CO2 lasers or radiofrequency wands, they operate on the principle of controlled thermal damage.
Okay, so they're burning it.
Basically, yes.
Yeah.
They intentionally create microscopic burns in the tissue, hoping to shock the body's natural healing cascade into generating new collagen to repair the burn.
That sounds intense.
It is. And the FDA has actually issued stark warnings about potential adverse effects from these specific devices. They've noted severe complications like chronic pain, severe burns, and permanent scarring.
Burns and scarring in an area that is already fragile and covered in breaking capillaries. That sounds terrifying.
It really is a massive risk.
Yeah.
And a recent systematic review of randomized controlled trials published in the journal Maturitas, well, actually, it was in the journal Menopause by Zerzan and colleagues, they look really closely at the data.
And what did they find?
They concluded that CO2 laser therapy actually yields minimal or no significant differences in long-term outcomes compared to sham treatments.
Wait, so basically a placebo wand?
Exactly, a placebo wand or standard vaginal estrogen. The evidence base supporting lasers for this condition is currently standing on very shaky ground.
Wow, so the surface level creams are basically a Band-Aid, and the lasers might literally be burning the patient for a placebo effect?
Unfortunately, yes.
So if those aren't fixing the soil, what actually penetrates deep enough to rebuild the tissue? This brings us to the core biological mechanism of our deep dive today. Healing with fish DNA.
Yes. Enter polynucleotides,
Okay.
which you will often see abbreviated in the medical literature as PN or PDRN. These represent the ultimate cellular level soil repair for intimate tissues.
Okay, I know if you're listening to this right now, you are probably thinking the exact same thing I was when I first looked at this research stack. Wait, we are injecting fish DNA into human intimate areas.
A very common reaction.
Right, like, does this mean we are incorporating fish genes into our bodies? Are we going to mutate? Are there allergy risks?
What's fascinating here is that the biology is incredibly elegant. Polynucleotides are indeed DNA-derived fragments,
Okay.
and they are typically extracted from the gonads of highly purified male salmon or trout. But they absolutely do not alter human DNA.
So no gills?
No gills. You are not receiving genetic instructions from a fish. You're just receiving the raw, universal building blocks of life. And they are sterilized and purified at extremely high temperatures to remove any proteins that could trigger an immune response.
Got it. So it's essentially mining the fish for the basic chemical components of DNA, breaking them down, and using them as raw material.
Precisely.
Though I imagine because of the source material, strict medical protocols dictate that fish allergies absolutely must be discussed before a patient even sits in the chair.
Oh, absolutely. Any reputable clinic protocol makes a seafood allergy screening the very first step. If a patient is cleared, the treatment can proceed.
Makes sense.
But we really need to distinguish what these actually are. Polynucleotides are not volumizing fillers.
Oh, okay.
Patients are not getting the equivalent of like a hyaluronic acid lip filler injected into their intimate areas to simply plump the tissue up like a water balloon. They're classified as biostimulators.
Biostimulator. So how
Hmm.
does that actually work in practice? If they aren't just taking up physical space like a filler, how do they stimulate the tissue to rebuild its own scaffolding?
The process relies on the body's own natural enzymes. These polynucleotide chains are injected deeply into the mucosal lamina propria.
And just for clarity, the lamina propria being that rich vascular layer of connective tissue sitting right beneath the surface lining of the vagina.
Correct. Once injected into that deep layer, naturally occurring enzymes begin to cleave or slice the long DNA chains apart.
Right.
As they slowly break down, they progressively release small nitrogen precursors, specifically nucleotides, and free nitrogen bases.
So it's essentially breaking down into high-grade, highly concentrated cellular food.
Exactly. It creates a localized feast for the fibroblasts. By artificially replenishing the local pool of nitrogen bases, the dormant fibroblasts wake up.
They realize there's work to do.
Yeah, they become highly viable and metabolically active again, and they immediately start synthesizing fresh collagen and elastin fibers.
So they start organically rebuilding the 75% scaffolding that was lost to menopause.
They do. And furthermore, these polynucleotide polymers are inherently hydrophilic.
Meaning they love water.
Right. They attract and physically bind free water molecules within the tissue matrix, creating a moisturizing three-dimensional gel deep within the mucosa.
Oh, wow.
So the patient receives immediate deep hydration from the gel and long-term tissue regeneration from the awakened fibroblasts.
The theory is undeniably brilliant, but the jump from theory to clinical reality is often where these treatments fail.
Okay.
But I was looking at the real-world data from the Archives of Women Health and Care cohort study you shared, and it honestly blew my mind. I expected a marginal improvement, but women were seeing a 72.5% reduction in vaginal burning,
It's incredible.
a 71.4% drop in vaginal dryness, and dyspareunia, that severely painful intercourse we talked about, dropped by over 59% within a 90-day follow-up.
Yeah, and in another multi-center pilot study that combined these polynucleotides with hyaluronic acid, overall patient satisfaction jumped from 59% to over 80%.
That's a massive leap.
It is. And the clinical examinations show the tissue visually transforming back to a premenopausal state. It regains its natural rugae, which are the healthy, elastic folds of the vaginal wall, and completely loses that fragile petechiae-covered appearance.
It heals the bleeding,
Yes, the tissue literally thickens and becomes resilient again.
which means the substance unequivocally works, but getting it into that delicate lamina propria seems like a massive logistical challenge.
And that is the big hurdle.
Which brings us to the real focus of today's deep dive, the massive clinical debate over delivery methods. We have this potent biological cure, but the debate raging in aesthetic and regenerative gynecology is how to administer it.
Right.
We are looking at a battle between the speed of automated multi-injection machines and the bespoke, tactile technique of the human hand.
The rise of automated multi-injectors for refractory dryness is a fascinating trend. Our clinical sources heavily detail devices like the U225 EVO mesoinjector.
I read the specs on the U225 EVO in our stack, and it sounds like a pneumatic, high-speed sewing machine. How does an automated multi-injector actually operate in a clinical setting?
Well, it is a highly calibrated pneumatic device that rapidly fires a needle into the tissue at a perfectly consistent, mechanically locked depth and dosage.
Okay.
So the practitioner glides the device over the tissue, and it delivers hundreds of uniform microinjections in a matter of minutes.
Hundreds.
Yes, and the manufacturer argues that this offers fast, flawlessly uniform delivery of the biostimulators across a large surface area.
But wait, you are injecting needles into the perineum, the vestibule, and the vaginal walls. These are some of the most densely innervated, pain-sensitive areas on the human body. How is a high-speed automated needle machine not agonizingly painful for the patient?
It actually comes out to neurology, specifically the gate control theory of pain and nerve conduction velocities.
Okay, break that down for me.
So the needle on the U225 EVO moves so incredibly fast, it's firing at very high hertz frequencies, that the mechanical sensation of the vibration and the speed of the puncture actually outpace the nervous system's ability to transmit the sharp pain signal to the brain.
Wait, really? It just outruns the pain?
Yes, the physical speed acts as a neurological distraction. It makes the procedure significantly more comfortable for the patient.
That's amazing.
And it's highly ergonomic for the doctor, too, who doesn't have to suffer from hand fatigue while manually pushing a syringe hundreds of times.
Okay, so the machine gives you fast, mathematically uniform hydration, and it essentially hacks the nervous system to bypass the pain. Why would a doctor ever choose to do this manually by hand? Isn't the vaginal canal just a relatively uniform, smooth tube of tissue anyway? You just glide the machine in and let it do the work.
That is a very common misconception, and it is exactly where the Lias Med Clinic protocols heavily push back.
Ah, okay.
Because the internal intimate anatomy is absolutely not a smooth, uniform tube. The vestibule and the vaginal mucosa are highly irregular. They have complex curves, deep folds, and varying topographies.
Not to mention the structural history of the patient. Like many women have profound, unique scarring from childbirth, episiotomies, or previous pelvic surgeries.
Exactly. Tissue thickness varies wildly,
Wow.
not just from patient to patient, but millimeter to millimeter on the exact same patient.
Right.
The mucosa covering a scar from an old tear is going to have a completely different density and depth than the healthy tissue right next to it.
So if a doctor uses the automated sewing machine on a highly complex, scarred, irregular surface, the machine just blindly fires at its preset depth.
Exactly.
It might perfectly hit the lamina propria in one spot, but completely miss it in the next because it passed over a raised scar.
The machine loses all ability to adapt. It delivers a fixed needle count at a fixed depth. But by utilizing the manual technique, the doctor's hand relies on constant tactile feedback.
They can feel what they're hitting.
Right, the practitioner can actually feel the specific resistance of the tissue through the needle. They know intuitively to inject slightly deeper where they encounter thick scar tissue or pull back to a shallower depth where the mucosa has severely atrophied and become paper thin.
It's the difference between mass manufacturing and a bespoke tailor.
Exactly.
Like the automated machine is brilliant for uniformly treating a large, flat area, like perhaps the outer skin of the abdomen or thighs. But for intricate, deeply personal, highly irregular anatomy, the manual technique offers a necessary level of customization.
It does. And if you look at the highest level of clinical evidence currently available, which is the 2025 Maturitas randomized controlled trial, that study definitively proved the efficacy of these specific mucosal injections against a placebo.
Right, the gold standard.
And that entire gold standard study relied entirely on manual hand injection, not automated machines.
So the foundation of the evidence base is built on the precision of the human hand. Even if a full hand-injected treatment takes 40 minutes compared to perhaps 15 minutes with the machine, that extra time spent feeling the tissue and making micro-adjustments is arguably the core value of the therapy.
It is a deliberate trade-off. Automated injectors provide fantastic uniform hydration for large areas of refractory dryness, but the manual hand injection provides true bespoke architectural repair for complex anatomy.
So if you were actually considering booking this therapy to fix refractory dryness, what does walking into that clinic look like? Because this isn't, a simple 5-minute Botox appointment where you get a quick injection of fish DNA and walk out completely cured.
No, not at all. According to the detailed clinical protocols from the Women's Health Clinic and the MDPI pilot studies, the foundation of this treatment is patience.
Patience.
Because we are relying on a biological process, the slow stimulation of fibroblasts to build new collagen, it requires a dedicated course of treatment. A patient will typically undergo 3 to 5 separate sessions spaced 2 to 3 weeks apart.
And what actually happens in the room during that 40-minute manual session?
Well, after a thorough medical assessment to rule out any active infections, a high-strength local anesthetic cream is applied to the mucosal tissue.
Okay, good.
And then the practitioner uses an incredibly fine needle, often a 30 gauge or 32 gauge, which is barely thicker than a human hair, to administer a grid of microinjections.
But based on the protocols in our stack, they rarely inject just pure polynucleotides, right? They usually mix a specific biological cocktail in the syringe.
Yeah, most advanced protocols, utilizing product lines like Nugen, they combine the polynucleotides with non-cross-linked hyaluronic acid. This provides immediate, soothing surface hydration, while the deeper DNA fragments begin their work. And crucially, they also mix in mannitol.
Mannitol acts essentially as a biochemical bodyguard for the hydration, right?
It does. It is a potent antioxidant. In a highly inflamed, atrophic environment, the body generates free radicals that rapidly destroy injected hyaluronic acid.
Just chew it right up.
Exactly. But mannitol scavenges those free radicals, protecting the hyaluronic acid and allowing it to survive much longer in the tissue.
Now, if you are using a needle, whether automated or manual, to deliver hundreds of injections into a highly vascular area, there has to be a physical toll. You can't just hop off the table and go for a strenuous bike ride.
No, patients must expect localized side effects. There's mild stinging during the cellular uptake phase, localized swelling as the hydrophilic molecules draw in water, and ecchymosis.
Ecchymosis being the clinical term for localized bruising caused by the needle nicking tiny blood vessels.
Right. Those symptoms generally resolve spontaneously within a few days. But practitioners are strongly advised by the clinical guidelines to aggressively manage patient expectations.
Because it's a journey.
This treatment is costly. It requires multiple, somewhat uncomfortable visits, and it takes weeks for the cellular signaling to actually mature into new collagen scaffolding.
It is also not permanent, right? Menopause is an ongoing, lifelong systemic reality. The ovaries are not turning back on.
Exactly.
Even with an 80% patient satisfaction rate, the soil will eventually begin to deplete again. Patients typically need to return for maintenance sessions once or twice a year to sustain that regenerated tissue.
If we connect this to the bigger picture, we are witnessing a profound philosophical shift in how medicine treats intimate aging.
We really are.
For decades, the standard of care was purely palliative. We gave women messy creams to temporarily mask the symptoms of decay. We are now moving into genuine regenerative medicine, actively commanding the body's dormant cells to rebuild structural integrity.
It's amazing. Let's briefly recap the journey we've been on today. We started by confronting the silent epidemic of genitourinary syndrome of menopause, a condition just destroying the quality of life for up to 80% of women through severe structural tissue collapse.
Right.
We explored how surface-level moisturizers fail to reach the problem and how aggressive lasers carry FDA warnings for burns and scarring. Then we unpacked the biological marvel of polynucleotides, highly purified trout DNA fragments acting as deep tissue biostimulator.
Nature's building blocks.
Yeah. And finally, we navigated the frontier clinical debate, balancing the painless, rapid uniformity of automated multi-injectors against the bespoke, tactile precision of the human hand navigating complex vaginal topography.
It really highlights how advanced biological materials and clinical engineering have to evolve in tandem to solve our most complex physiological problems.
Absolutely. So whether you are experiencing this right now, will experience it in the future, or know someone who is suffering silently, the landscape of intimate aging has fundamentally changed. The era of doctors telling women to just endure it with a tube of lubricant is ending.
The science of regeneration has finally caught up to the reality of the suffering.
Which leaves us with a final, slightly wild thought to ponder. If medical science can successfully harness the raw building blocks of DNA from a fish to completely reverse tissue atrophy and restore a resilient vitality in the highly complex, scarred environment of the human reproductive system, could this exact same localized automated injection biostimulation be the key to regenerating other hidden mucosal systems as we age?
That's a huge question.
Could the degrading linings of our gastrointestinal tract or our respiratory system be next? I mean, if we can master the delivery mechanism to heal the soil in one part of the body, why not the rest? Until next time, keep diving deep.